good afternoon, everyone. We'll kick off, and thank you. It's a fantastic turnout, and happy International Women's Day to everyone, including our allies there, Noel and John. And there's about 130 people online, which is just fantastic turnout. So we'll need to make sure that, you know, Lena's out there making sure they can hear us and all those kind of things. So before we kick off, Imelda's going to do an introduction. Thank you.
Hi, everybody. Some people know me, Imelda from Oncason. So, as I said, we're going to celebrate International Women's Day is on Saturday. So I hope everybody does something nice for themselves on Saturday. So I have a lovely reading here, Women Who Change the World. And we'll just do the bells just so we can have a little quietness. Women who change the world. There are women who make things better simply by showing up. There are women who make things happen. There are women who make their way. There are women who make a difference, and women who make us smile. There are women of wit and wisdom who, through strength and courage, make it through. There are women who change the world every day, women like you.
Thank you. Well said. So we're going to have a focus today on, you know, sometimes when we think about women's health, we think about gynae and childbirth and everything, but of course, there are many, many wider aspects to women's health, and we're very, very lucky today to have advanced nurse practitioner, very experienced clinician managing heart disease, who's going to talk to us today, Shirley Ingram.
Thank you. Hello, everybody, and hello to everybody online. And it's great to see so many people in the room. Hello. And I think the women you described there, I think that's all those women in the room today, and a couple of welcome gentlemen as well. Not to leave you out. We wouldn't want to do that. So it's great, International Women's Day. We get a day to ourselves. Hope you've all something nice planned for Saturday. I'm running a conference for cardiac nurses, so won't get much time for myself on that day. But as Susan says, you know, we tend to think of gynecological or maternal issues when we think about women's health. But if I could ask the room, what do you think the biggest killer of women is, to start off on a gloomy note? Yeah, now you see, I've spoken to Oncason before. So you remember, and they were an excellent group and they had all the answers right. But you're absolutely right. It is actually heart disease. Whereas if you ask most women, they will think cancer or probably breast cancer. But we're 13 times more likely to die of heart disease than of breast cancer. You know, and it is a very sobering fact. But the positive news is 80% of heart disease can be prevented. So I'm just going to run through a few of my slides today. I'm sorry if some of you have seen them before, but for those of us joining online. So as I said, heart disease is the biggest killer of women, and 1 in 4 women will die from heart disease and also stroke. So when we say heart disease and stroke, we're talking about vascular disease, which is a disease of our blood vessels. And the same blood vessels run through our whole body, from our kidneys, our heart, our brain. I call it in layman's terms the plumbing of the system. So once we hit the age of 40, then our risk actually increases further. So why women? Now, those of you who I've spoken to before will know this. So we are very well protected by our estrogen. You know, we all think of heart disease as a men's disease, don't we? We all know somebody, some younger man who's had a heart attack. We rarely kind of think of a young woman having heart trouble. And once our estrogen level drops, our hormone protection drops, and therefore our risk of heart disease is higher because we're losing our circulating estrogen. And now we can see more women heading into perimenopause a lot earlier in life. So the risk starts earlier. But the good news is 80% of this can be prevented. So I like this slide. I know it's a little bit complicated, but when I talk about the top of the box there in red, ischemic heart disease, really that means heart attack, angina, things that are likely to come on, limit your life and make you feel very unwell. And then underneath that, we have stroke, which is vascular disease. And if you can see then, it's the same in men and women, the biggest cause, but much bigger than all the cancers. And that just kind of goes to show what I was telling you about earlier. So what are we talking about when we talk about heart disease? That the heart can have a variety of things wrong. I always say it's the pumping, the plumbing, or the electrics. So the electrics can cause different funny rhythms of the heart, and I won't be talking about that today. And I won't be really talking about the pumping of the heart, which you've probably heard of a term called heart failure. And again, I could give a whole, or get my colleagues in heart failure to talk about that, because that is very prevalent among women. But what I'm talking about today is the plumbing, and this is the plumbing here, the arteries of the heart. And they're very important because they supply the heart with oxygen so that the heart can beat and do its job for the rest of the body. And when we hear of someone who has angina or a heart attack, this is what they have. When you go deep down into the plumbing, into the arteries, you've all heard of narrowing in the arteries of the heart, but the technical term is atherosclerosis, and it's plaque buildup isn't even really the correct term. It's a very complex process, but simplified, it is a narrowing occurring inside the artery of the heart. So I always say to my patients, it's like you're on the M50 and 2 lanes are shut and you only have 1 lane to get through. And what if that lane blocks off completely? Well, then you've no traffic getting through. So that's kind of a simple analogy for it. But what happens when it starts to narrow or block is that the blood supply can't get through to the heart muscle, and we need our heart. Our heart needs to pump. So why women? And I was actually on a webinar last night, just to make sure I was completely up to date with everything before I came to you today. And I think, you know, the big fact is that, you know, heart disease is not just common here, it's common globally. It's on the rise in younger women. So I'm glad to see some younger women here, and hopefully younger women online, because it is preventable. And it is more lethal in women. So we know studies have been done by the Global Heart Hub, by the European Society of Cardiology, that show women are undertreated, underdiagnosed, and under-researched. So a lot of the evidence that I'm talking to you about was done on men's hearts, and men's and women's hearts, like everything else, are quite different. So as I said, we think of men having heart disease. And one of the things that the research has shown, when you ask women, they don't really understand the signs of heart disease. So if I said to you, what are the signs of a heart attack? Would you think they're different in men and women? No. Yes, actually they're not. They are the same. There's become a bit of a narrative that women have different symptoms. They can, but usually it's the same. Chest pain is the main sign of a heart attack in men and women. Now, women can have a whole load of different symptoms as well. So never, basically it's to never ignore the symptoms, and we'll go through that in a minute. Women delay access to medical care. Why do you think that is? Why are we all delaying going to hospital? I've done it myself. We're busy, we're caring for children, we're caring for relatives, you know, something always else has to be done. If you take an ECG on a woman's heart, sometimes it doesn't always show up what's going on the same way it would on a man's heart. And that can often lead then, as I said, to women not being diagnosed. And by the time a lady is diagnosed with heart disease, it's probably well established. You know, it's probably been there for a long time. And also as women, we have a lot of other illnesses, especially when we hit the menopause and we're going after the menopause. You know, we've osteoporosis, we might have a bit of COPD, asthma, diabetes, a bit of blood pressure. So we've a lot of other things going on as well. But now for the good news. So 80% of this is preventable, and it's never too late to start. We can't stop our estrogen declining, but HRT now is being prescribed much more frequently in primary care, which is wonderful. So it keeps our estrogen levels high. Again, there's caveats with prescribing HRT in people who've had heart disease, so that has to be treated very carefully. But from a primary role, our estrogen levels now are staying a bit higher longer. We can look at our cholesterol, we can manage our blood pressure, and as weight changes, when we're older, it is quite difficult. There's many reasons why we gain weight as we get older, but again, there's plenty we can do about that. So a lot of my slides here are from the Irish Heart Foundation, and if you get time to check out their website, they have a whole series called Her Heart Matters, and they have great resources on that. So symptoms to look for in a heart attack. So the main common one, as I said, is chest pain and shortness of breath. And that might not mean that you're puffing and panting, but if you try and speak a sentence, you just might not be able to get the words out. You can feel dizzy or lightheaded, sweating, nausea, vomiting. Again, both men and women can have these signs. For me, it's like a feeling that there's something seriously wrong here. This is just not the normal aches and pains or the normal tummy bug. It's something different going on here. You have a sense of kind of that this is serious, a sense of doom it's often being caused. But women can also have different symptoms: indigestion, nausea, pain in the shoulders, pain in the jaw, throat, neck. So slightly different things. Heart attacks come on suddenly, usually. So, you know, you're fine 1 minute and the next minute you're feeling these symptoms. And that is a key warning sign as well if symptoms come on suddenly. But what I see in my clinic mostly is people who come to me with anginal pain. So this is more gradual onset. And you think back again to the plumbing that I showed you. You know, the narrowings in the heart don't just happen overnight. It's a gradual process. So by the time the narrowing has kind of got to 60, 70%, you might be feeling a few symptoms. So you go out for your usual walk, it's a particularly windy day, or you're walking up a steep hill, and suddenly you're feeling a bit of an ache or a pressure in your chest, your jaw, your throat, your arms, a bit of extra breathlessness. If that is happening frequently enough, it's worthwhile going to your GP to have a chat, because that could be the sign of angina. Usually then you sit down, take a rest, and if the symptoms go away, that's another kind of warning sign. And then we can have treatments and investigations to have a look for that. But don't ignore those signs. Don't say to yourself, oh, I'm just putting on a bit of weight, or I'm not as fit as I should be. You know, if they're new and if they're happening all the time when you exert yourself, go and ask your GP about that. Breathlessness is another common sign of heart disease in women. And breathlessness, as I always say, it's a tricky one to diagnose, because it can come from the lungs. If there's a problem with the lungs, it can come from being overweight or unfit, but it can also be a sign of angina or heart disease. So again, don't ignore these symptoms. Listen to your bodies. So name the risk factors for heart disease. Shout it out there, somebody. What do you think is the biggest risk factors for women?
Smoking.
Smoking is a risk factor, yes. Stress, yes.
Overweight.
Being overweight, yes. High cholesterol, you know it, yes, you do. So we're going to go through a few of these. Interesting for women, the most significant risk factors are high blood pressure, high cholesterol, and diabetes. You know, so smoking, yes, really important. And I think only time will tell now with the younger people vaping what impact that's going to have in the future. But for women, the top three are hypertension, high cholesterol, and diabetes. So there's also, you did great there. You know, everybody, I think by now, hopefully knows the big risk factors, and smoking is indeed one of them. But there are a lot of what we call sex-specific risk factors for women too. So early menopause, and that's because the estrogen protection has gone down earlier. If you have diabetes when you're pregnant, if you have high blood pressure when you're pregnant, if you have premature deliveries, and also polycystic ovary syndrome, and some of this inflammatory autoimmune disorders, so like rheumatoid arthritis, things like that, they all pose extra risks for women for developing heart disease. And then I think this is really important, is the under-recognized risk factors there you see. which somebody said stress. So absolutely, it's a very hard thing to measure because stress is very subjective, but we call these psychosocial risk factors. So how much stress is in your life can lead to you taking up unhealthy behaviors, domestic violence, poverty, poor health literacy. So that's what we mean is that we're bombarded with information, aren't we? On the internet and the Instagram and the TikTok. You're all on TikTok, I suppose, and the Twitter. So, we're bombarded with information, but what's true, what's accurate information? And then often we don't understand what we're reading either. So these are really important things to think. And I ask my women about these things as well, especially younger women, as well as the ones I mentioned. Somebody also mentioned being overweight, lack of exercise. That's really important. If I could prescribe exercise on a prescription pad, I would. And smoking, obviously. We'll just go through a few of these. So very briefly, how are we doing for time? High blood pressure affects men and women equally, and it's the silent killer, really. They say half of us are walking around, we don't know we've high blood pressure. Then of those of us who do know we've high blood pressure, half of us are on treatment. And then of those of us who are on medication, half of us, it's not doing what it says on the tin, do you know? So blood pressure is something globally that's really not well managed. And you would have thought maybe before, I remember when I started training, they used to say blood pressure was 100 plus your age. So you get to 80 and you're supposed to be allowed to have a blood pressure of 180. But it's not like that. We aim for the target of 130 over 80. So when you go to your GP, ask what your blood pressure reading was. That's low. It can be difficult for people to achieve that. So blood pressure is largely genetic and hereditary, but it can also be increased by your lifestyle. So increased salt intake, obesity, smoking, and alcohol, and lack of exercise. So how do we treat blood pressure? Well, the most important thing is to have it checked, because sometimes we might not even be aware our blood pressure is up, except when you're standing giving a talk, then you can kind of feel it. But mostly we don't know. So every time you go to your GP, you usually get your blood pressure taken, ask what the result is, write it down. Some people like to check their blood pressure themselves, and that's brilliant, but I would say make sure you're using a proper machine that's been validated and it's not going to give you incorrect readings. If you're on medication, don't stop them because you feel like your blood pressure has gone away. Look at the salt on your diet. This advice kind of goes across the board. Move more, eat less, more fruit and veg, stopping smoking, and relaxation. So there's a lot we can do to help us lower our blood pressure, but sometimes it's not enough. And we need blood pressure medication, and that's where you engage with your GP or your GP nurse in the community about taking medications. The next risk factor we mentioned that was really important for women was high lipids. So we know that really by the term cholesterol. Everyone knows that term, but actually there's 4 fats in our blood that we measure. And so overall we call them lipids. So we need a certain amount of cholesterol. We need it to make our vitamins, to line our nerves, and to make our cells in our bodies. So there's a myth that we don't need any cholesterol, but we do. We just don't need it in the levels that we all have, have now, due to again, it's a genetic thing, and it's also due to a high fat diet. But next time you're getting your cholesterol level done, ask whoever is giving you the results, what's your LDL? So there's 4 fats in your blood: cholesterol, LDL. Now you know that because you've probably heard of the lousy lipids. And then there's your HDL, the happy lipids, and they sort of balance each other out. And we're learning now that the LDL is really the one that we need to be concerned about to reduce your risk of heart disease. And those targets and numbers are changing all the time. We would say an LDL of less than 2.6. But if you have heart disease or have had a stroke, a heart attack, angina, it should be less than 1.4. So that's a tough number sometimes for people to get down to. I had a gentleman in my clinic the other day, and his cholesterol was 8, but his LDL was 5.8. So that was more concerning to get that LDL down. And again, it's something that can rise after menopause. So with estrogen, our HDL is nice and high, and that's the good one. And it balances and keeps the lousy one down here, and then that changes over time. So there's another level to ask your GP about is your triglycerides. And they're a major source of energy, and they're increased with increased sugar and alcohol, but they can also be a sign that you're tipping into diabetes. So again, it's useful to know that level in case you need to get checked out for diabetes. And what happens with the cholesterol is, as you can see, it kind of beds down, it goes in through the blood vessel wall, and then it causes these narrowings in the blood vessel wall. So that's why it's so important. And again, it's not just our hearts, it's our brains as well. So how do we achieve a normal cholesterol? Well, we all moved to Spain or Portugal or Greece, which would be great. And we're all very good on our holidays, apart from a few too many drinks maybe. But, you know, really, if you think about if we're lucky enough to get away, what we eat when we're away. So plenty of oily fish, lean meat, fruit and veg, and just cut down on the brown, on the white things, the white pasta, the white breads, the sugars, all of that. So by doing that, you're cutting down on your fat, increasing your fiber, your fruit and your veg, and your oily fish. I don't know, do you like a bit of mackerel or salmon or trout, if we can get it, and to increase our exercise. So again, it's the same for blood pressure, you know, all the advice is the same for all of these things. Now, somebody mentioned putting on weight as well earlier. And this is something we struggle with, especially when we hit the menopause. And as we know, obesity is a rising problem in our population. You know, I like even, what was it, January, all the Easter eggs are out in the shops already, you know, so we're bombarded, and it's really, really difficult as the consumer going in to resist all of these things. But when we add on an extra bit of weight and it keeps going on, there are risks to that. I'm not going to go through all of them, you can see them there, but like everything, all of these risks are all interlinked. But there's plenty of support in the community. We've community dietitians in this building that you can be referred to for weight management, for high cholesterol, for diabetes. And there's also plenty of local expertise with the Heart Healthy Network. So there's a lot of resources in the community to help people who are struggling with weight gain and obesity. It's gone a bit out of sync here, but I put this slide in because it should have come in after the cholesterol slide. They've got a bit muddled up here somehow. Apart from lifestyle changes for high cholesterol, who's on a statin? Okay, so there's a lot of myths out there about taking a statin, and I think it's important that you find the correct evidence-based information, and it's obviously your choice if you want to take a statin or not, but just to understand why you're not taking it, and to just, you know, inform yourself through reliable sources, because there's plenty of misinformation out there. Very widely studied drug out since the 1980s. I remember that when I started training, it was like the wonder drug, you know. So now we've 40 years of evidence, and it shows that it does reduce the risks of heart disease and stroke. Muscle pain is something that people feel that they get when they're on a statin. We can get muscle pain for various different reasons. If you feel it is severe, talk to your GP and we can check and switch it to another one. So there's always another option that we can work with. Don't just, again, like with the blood pressure, don't just stop your medications. Sorry, now jumbling around here. That's just a little bit more about managing your weight. And I think the thing that works for me was, the biggest thing for me is take out a smaller plate. It's very hard. I was buying a new dinner set recently, and all the plates are massive, aren't they? We break a lot of things in our house. Well, I do, so I had to keep buying them. So, you know, I just use a smaller plate, a smaller bowl, and it is amazing how you think you're eating more even by just using a smaller plate. That's just one little tip. And drink plenty of fluids to fill you up. Physical activity. then really, really important. And again, there's lots out there in the community. If you go onto the HSC website, and I think of a few QR codes here, I don't know, hopefully they still work. You know, there's a lot of community walking groups, active retirement groups, you know, there's plenty there. If people are struggling to find information, ask your GP to refer you to the local social prescriber, and they will link you in with groups and everything that's going on in the community. Because, you know, I have a really good friend, you know, and I'd say, I'll meet you for a walk. And she said, I don't walk. I said, what do you mean I don't walk? I don't like walking. I said, how can you not like walking? I just don't like walking. So, you know, there are people out there who just do not like exercise. It just doesn't do it for them. So we have to try and be inventive and think of other ways. Swimming, Pilates, bit of yoga. You know, there's a range of things. You don't just have to be pounding the pavements if it's not for you. But the goals are about 30 to 60 minutes, at least 5 days a week. You're like, that's tough. I struggle to fit that in. You know, it's not an easy thing to do, but just to bear it in mind and try and break up that exercise throughout the day, especially in this building. If you take the stairs here, you're a champion, I have to tell you, you know. They're special stairs in this building. So doing that a couple of times a day is getting in your activity levels. But the biggest thing is going from doing nothing to doing something, you know. Getting up and just getting moving and doing something that you find, especially now with the longer evenings, the milder weather is coming, we can get out and about a bit more. And as I said to you, if I could write a prescription for exercise along with the statins and the blood pressure medications, I would. And these are all the benefits of exercise. Apart from making us feel better, we think, oh, it'll help me lose weight. That'll be the number one thing. But it also reduces your blood pressure, reduces your heart rate, improve your lipid levels, your cholesterol. And for women too, which is kind of crossing over into another speciality, is something that we get as we age, which is osteoporosis or thinning bones. We fall over, we get a fracture, that can cause a whole load of other complications. So exercise keeps our muscles stronger, reduces the rate, the risk of falling as well. And the heart is a muscle. My first nursing tutor said the heart is a pump, and that is it. It's a muscular pump, so it needs to have its own exercise regime as well. And then these things, which are the bane of my life, I have to say, people come into me and I say, so why are you here? Well, my watch said my heart rate was 200. And I say, well, how did you feel? Oh, fine. I just looked down and it said 200. So these watches, some of them are brilliant. You know, they can show your ECG tracing and everything on it. But they need to be taken with a pinch of salt into how you're actually feeling, you know. And I do think people get a bit obsessed about the watches. On the other hand, they're good for tracking your steps. Do you like to count your steps? Yeah. My friend's mother is 80 and she said they were away and she said, oh my God, I've only got up to, I'm 400 steps off my 10,000 steps. So she was up in the bedroom and she could hear her just walking around the bedroom to reach the dig, you know. There's not a huge amount of evidence that 10,000 steps, but it doesn't matter. It's encouraging us to get moving and get walking, you know. And I know myself, some days in work, I'm hardly moving around because you're doing a clinic, you know, so you have to try and make up the steps then by doing the stairs. So they are useful, but just, you know, take them in with a pinch of salt. Smoking, look, we've talked about smoking for how many years is the smoking ban in place now? Now we're talking about a different thing, which is the vaping. So vaping, I think I have a slide on that as well, but giving up smoking still is the single biggest thing you can do for your heart health by quitting smoking. And still surprisingly a lot of people smoking. And again, we have supports in the community. I never smoked. I can't say how difficult it is. If it's anything like giving up chocolate, I think I'd never give up smoking. So it's really hard to stop smoking, but we have supports. And the HSC quit lines are wonderful. I have quite a few patients on that, and you can get free nicotine replacement therapy. So the supports are really out there, all available for you. We want to help everybody stop smoking. Why do we want people to stop smoking? I used to say, if I made a glass now here of all these concoctions and said, well, we'll all have a drink of this, you wouldn't drink it. but we'll inhale it into our lungs. And we don't know, like the vapes contain a lot of toxins and a lot of chemicals, and they contain nicotine. So they're still a stimulant. They're still putting strain on the elastic blood vessels of our heart and our brains. They're still making our blood cells really sticky, which causes heart disease or heart attacks. You know, so again, these young people are being sold the vapes with all these fantastic flavors without really we don't understand yet what the consequences of that would be. Nicotine damages the lining of our plumbing. So if the lining of the arteries are damaged, then all the big cholesterol molecules then can burrow into the wall and cause the narrowings I was talking about. It increases the heart rate because it's a stimulant, increases the blood pressure, and it makes your blood cells very sticky. And that's the thing about heart attacks. When you have a heart attack, your body wants to clot and plug the holes, plug the damage. But by smoking, you're constantly making little clots in your body. And obviously the risk of lung cancer as well. And it's never too late to stop. And that's just some of the things in a cigarette there. You have cadmium, which is in batteries, butane, which is in a lighter, methane, arsenic, arsenic and old lace, the old play, rocket fuel, paint stripper, you know, toilet cleaner. So we wouldn't take these in any way, but you know, and sometimes this puts people off more than the risks of heart disease. So if you're only learning this today, that's at least one message to take home. So someone else mentioned stress here today, and we all need a bit of stress or we wouldn't get up and go out every day. But it's when the stress becomes unmanageable. And, you know, I see in our population now huge amounts of stress, you know, social stress, personal stress, family stress, work stress. You know, sometimes you feel there's no getting away from it. And it's when the balance is shifted where you can't cope with the stress. And stress, it's a hard thing to kind of prove, but the evidence does show that more stress leads to chronic anxiety and chronic depression, and people with poorer mental health do have a higher risk of heart disease. So how does stress affect our hearts? Again, like the smoking, like the blood pressure, puts up the heart rate, puts up the blood pressure, can encourage quick fix unhealthy behaviors, you know, when we're reaching for the glass of wine or two. And then it can become something deeper, anxiety and depression. I mean, I'm just flying through this again. This is another whole topic we could spend ages on. But there are simple things that we can do: relaxation, yoga, talk to somebody. You know, there's the big HSC campaign. Talk to someone, tell them how you're feeling. Meet your friend, go for a walk, talk it out. Don't suffer in silence, you know. And then talk to your GP as well. You know, and sometimes we need something to just help us get over a really stressful time for a short period of time, and that's okay. Alcohol. So you all have to give up alcohol immediately. So the evidence doesn't say that. Alcohol in moderation, and that is the message here. Moderation is okay. And do we know what moderate alcohol is? Well, I've given you the answer there now. So it's at least 1 to 2 alcohol-free days a week, and units. So men 17 units of alcohol and women 11 units. And these are what our units are. So a pub measure of wine, not the home measure of wine. Same as well, a pub measure of a spirit or a glass of a beer. Now, obviously the different strengths of alcohols can have different units. You know, the higher percentage of alcohol, the higher the unit. But this is in rough terms here. So kind of, I say to women, it's about 1 bottle of wine over the week. So I ask people, how much would you drink? Well, you know, a few and this. And I say, how many bottles are you bringing to the recycling, or the cans are you getting your money back when you put it in the chute? And that's a really good way of counting up how much alcohol you take every week. So again, it's just about cutting it back, having drink-free days. You don't have to give it up altogether for risk prevention, but just to cut it back and stay within your units. So these are the building blocks to prevent heart disease and to prevent stroke. It can start at a young age. you know, there's no kind of mystery here really. And we've known about these things for a while. We're just getting tighter on the guidelines and the limits and our levels. Less salt, less sugary or fatty foods. Moderation really is the key for everything. So I like this slide here. Be part of the movement of women who want to see change and protect all our female friends, relations, cousins, aunties, daughters, nieces. And, you know, her heart does matter, especially this International Women's Day. We don't ever get a day we just talk about women's health. And also just to flag here, Tallaght Hospital did a fantastic podcast series for anyone online there who wants to take a picture of that. I don't know how well that QR code is coming out, but you could Google it. So this is a series we did on women's health, and it doesn't only cover heart disease, it covers bone health, brain health, gynecological health. So it's a series of podcasts that you can listen to on YouTube or on your podcasts, all about women's heart health. And this was a really good series. So I'm just going to give a little shout out to that. Have a listen to that. And our healthy, Sláintecare healthy communities as well. And we've many healthy community resources in Tallaght. And that's just the smoking ones. Now, these telephone numbers might be a bit out of date now, but if you Google these, you will find information. And these are the QR codes. Again, these might be a little bit out of date, but they're there. They're available in the community just to link you through. A lot of resources for home exercise. I like to do things like that at home myself, you know. If you have 20 minutes just in the kitchen with the dog, just do a little bit of stretching and bending. And the Irish Heart Foundation have wonderful resources online, and they will send you information in the post if you want a booklet. It's all readability tested, a great series of patient information. And they also have a nurses support line as well in the Irish Heart Foundation. So if you know somebody who's struggling with managing their lifestyle, managing their risks, or if they're struggling after they've been diagnosed with a cardiac condition, ring them up, have a chat, they will help you. And that's it. Thank you.
So thank you. Now, just to let you know, our second speaker hasn't been able to make it for personal reasons. So we were delighted you could give us a bit of a longer talk with all of your, that was brilliant. So we're open now to questions or comments, if anyone would like to say anything.
Can you come back slide with podcast? I think.
Oh yeah, sure.
Okay.
Sure.
Any other questions while?
Here, I'll make it a bit bigger there. Hold on. No.
Better? Okay.
No, it's a great resource that I've listened to a few of them myself and learned things.
Okay.
I have questions
Mm-hmm.
about my children. Is have surgery in heart, but is after surgery. Is now have to care of is Crumlin Hospital in Tallaght too. Is it's okay or need something no more? Or if I have to care of this GP or cardiology
For your children,
it is everything okay.
I would say linked with the Crumlin, obviously, if you're there, because they're the pediatric. I mean, I'm talking today about adult heart problems. So yeah, and link any questions like that, always link back with your GP, because your GP will always get a letter with information from whatever doctor you saw or your child saw in a hospital. The main link is your GP. Yeah.
If I have cardiology who provides, it's okay, yeah?
Yes, yeah.
Okay.
Yes, that's the best. Yeah.
Can blood pressure medication be reduced?
Yes, and that's the important thing, is to have regular. That's a really good question.
I've just been reduced from 16 to 8.
Yes. So did you have a 24-hour blood pressure monitor?
I didn't.
You
No.
didn't. So okay. Was that? Yeah. I mean, some people have it reduced because they're, might have a few side effects. They might reduce one medicine and add in a different type of medicine, so they balance out. or maybe your overall blood pressure levels, because you're losing weight or you're getting fitter, are naturally coming down a little bit. So yeah, the most important thing is to have it checked regularly. And that is a really good point, because if you start on blood pressure medicine, some people think, well, that's it then. I don't need to get it checked, but you really need to get it checked regularly. 24-hour blood pressure monitor is the best way to diagnose high blood pressure and see if the medicines that you're taking are working. I see a lot of people who are on one blood pressure medicine, but their blood pressure is still high. You know, so yeah, it's a fine-tuning juggling act. Yeah.
Just for the people online, that question was about whether you could reduce your blood pressure medication. No, we should have said that. I mean, I would add into that as well that things change as you get older. So, and what you don't want when you're older is to be having periods of very low blood pressure, because that increases your risk of falling. So a GP or a nurse or a specialist may say, do you know what, your blood pressure is very tightly controlled, and that might be appropriate when you're in your 50s, but maybe if you're getting older, we want to make sure that you don't get, you know, low blood pressure some of the time. It's really interesting. In Germany, something like 30% of women are treated for low blood pressure. It's a cultural thing. And we just don't really do that at all.
The lower, the better.
They're given kind of stimulant-y kind of herbal treatments. It's funny, but
if your blood pressure goes down, would that mean the medication would be reduced?
if you had a very low blood pressure over time, or on your 24-hour it was looking too low, your GP may decide to reduce the dose. So they might just, as you've done, go from 16 to 8 or whatever. And it just depends on so many other things. Yeah. The most common thing in my experience, and John is a GP as well, is that people are put on a blood pressure tablet and they come back in 3 months and say, I only took that for a month.
I took the course. Yes.
I took the course of tablets.
The course, yes. Yeah.
It's really interesting. So it's about really emphasizing to people that it's, you know, that's why you should only go on to it if you really need it, which is why the 24-hour one is really important at the start to make the diagnosis. Because once you're on it, you can't be re-diagnosed without stopping everything, and it just gets very messy.
Thank you. So when you say low blood pressure, I always had low blood pressure when I was younger. Now the last one was a few weeks ago. It was 128 over whatever. Now where does that stand?
Perfect. It's right in the right place. Yeah. So that wouldn't be low, but you know, it's very normal.
Good reading.
Yeah, very good.
Yeah.
The other thing that it's funny, the more and more of these 24-hour blood pressures we do, like there's some places where they would repeat them every year, but actually resource-wise, that's not that feasible if somebody is well controlled. And also a lot of our patients, I don't know if any of you don't really like having it done that much. You know, you're being squeezed every 15 minutes, you can't sleep, you can't drive for that day, all those kind of things. So one of the international guidelines is that if you have a reliable machine at home and you take it morning and evening every day for 2 weeks, we can then look at the average of that. And that's nearly as good as a 24-hour, not necessarily for being diagnosed, but certainly for monitoring you. It's worth having. Now, I had another funny experience where, you know, some of the fancier machines will record your average blood pressure. Just make sure no one else is using it. Because then you get a family average, which is no good.
How often should you check, if you don't have a machine at home, how often should you get your blood pressure checked? You tend to do it if you go to the surgeon, but if you haven't been for 10 months, you know, should you go to the pharmacist and get it checked? Or
the guideline is once a year, but if you're on treatment and you have other things, I'd be saying every 6 months. But it kind of depends on how well controlled it is. There's no absolute right answer.
And how you're feeling as well. You know, if you're suddenly feeling, you know, tired or headaches, or you know, if you're not feeling off, first thing to do is get your blood pressure checked. And your local pharmacy can do that for you as well.
It's very handy.
Yeah. It's just being aware of it and being mindful of it, as you say. I took the course of tablets, you know, I didn't take them anymore.
I'm just going to go for these questions online as well, and then I'll come over to you. So, does salt raise your blood pressure? I know I never add it to food, but it is in food that I buy. And how do you know when you've reached your limit? There's a nice easy one.
So, well, they say, especially, well, if you're diagnosed with heart failure, you should not be adding any salt at all. There's enough hidden salt for all of us in our foods. But I think we like our salt on our spuds and things like that. But and our taste buds become nearly over accustomed to it. So they say no more than 1 teaspoon a day, but most of that's going to be hidden in your food anyway. So to answer that question is, I would just try and stop adding salt at the table. So if you're, you know, like my husband, I put the dinner down and he just picks up the salt and I say, would you just taste it first, please?
Yeah, and that's very common. And
You know, it's
yeah.
a habit.
Yeah.
So try and use other seasonings like pepper, not the low salt, because that's full of potassium. We don't really recommend that. But I think it's a very cultural thing, and it's a taste change.
Totally, yeah. The other thing you can do as well is if you put a tiny bit of lemon, if people really like that salty flavor, the bitter, there's lemon juice can be a better thing to add as well. And then think about pepper. But pepper tastes different to salt.
Or chili.
Or chili is another one that you can add, yeah. And sorry, you had a question over there?
Just one, a 24-hour heart monitor. What's that looking for?
Okay, so the question for people online is, what is a 24-hour heart monitor looking for? So
A Holter monitor.
yeah,
Yeah. So a blood pressure monitor obviously goes around your arm and it's looking for your blood pressure readings over 24 hours. People do get them mixed up sometimes. So a heart monitor is where you have the stickers stuck to your chest. And there's often a very long waiting list for those. GPs don't tend to put them on themselves. They might have access to blood pressure monitors. So what that's, do you remember I said at the beginning, the heart has electrics, plumbing and pumping. So this is looking at the electrics of your heart, looking at the heart rhythm and the heart rate to see if there's any funny rhythms. You know, we all get palpitations every now and then. We feel a skip beats or a little bit of a flutter sometimes. So if somebody is having a lot of palpitations, it can be nothing or it can be something. The only way we can see is to get the evidence. And you can bet eggs or eggs, you come into the doctor's surgery and you have no symptoms and your ECG is perfect and you go out the door and you start feeling it. So that's what a 24-hour heart monitor would show us. But I often suggest that if people are worried about palpitations, you can download, there's a gadget called the Alive Core, and you buy the sensor, it's about €100, and then you download the app. And when you feel a palpitation, you can put your fingers on this sensor and it records the heart rhythm onto your phone. It's a great gadget to have if you're having a lot of palpitations. Because then when you next go to your doctor or your nurse, you have the evidence on your phone. So it's called the Alive Core. So it's very good, but it costs money.
but I mean, go to your GP if you have palpitations, and they probably will refer you to have monitoring done. And sometimes they even do 6-day monitoring, you know, because
But there's
you know, you could put it on for 24
You'll wait
hours.
a long time
Oh,
for
you
the
will,
monitors.
you will,
So
yeah. Unless you have something that, like,
Yeah.
if we think you've something, an irregular heartbeat, like
Yeah.
atrial fibrillation, you might get in more quickly through
yeah.
maybe.
Well, you know what the biggest way to diagnose atrial fibrillation is? Feel somebody's pulse.
The old style.
The old-fashioned. People don't tend to touch each other much anymore. So checking pulses seems to be gone because we just put the monitors on and press buttons. And so if you're worried about any funny flutters, even feel your own pulse and see does it feel like it's regular or is it a bit all over the place? It's the easiest way to.
And in many ways,
You
we
know.
should all just know what our heart normally feels like, you know, just so that if something is different, you know, that's not, it's a bit like breast examination.
Yeah,
Most
exactly.
you should just get used to what your breasts feel like, and then you'll notice if there's something different about it.
And if you can't feel it in your wrist, just put your fingers on the side of your Adam's apple and rummage around until you feel the pulse there. And you're absolutely right.
Yeah.
What's normal for you? And then sometimes, oh, this is a bit out of the ordinary.
Now, if you have, you know, those palpitations you get, and often you notice them in bed at night. That's just one skipped beat, and you might feel that, but that in general isn't something we'd be too, especially if it goes back to normal afterwards and it's nice and steady.
Quite common.
Yeah. Now more questions, great, all coming in. What is thrombosis?
Here. Well, I suppose thrombosis is a more old-fashioned term, isn't it? People used to talk of someone having a thrombosis of their heart. It's a clot, and a clot that's what a thrombosis is. It's a blood clot that shouldn't be there. Because our bodies are supposed to clot. If we cut ourselves, we need to clot so we don't bleed. So a thrombosis would be a clot happening somewhere in the blood vessels that might cause stroke or heart attack. But we don't really use those terms, do we?
No, like sometimes in your veins, you hear about deep
Yeah.
vein thrombosis, you know, when your leg gets swollen and your veins are, yeah.
Yeah, it's a
blocked.
clot,
Yeah.
basically.
Just funnily coming down, I
Yeah.
read an ad, and it was, if you're on contraception or you're on HRT, go to your doctor and ask for a thrombosis check. So that.
Great, the doctors will love that.
When you just said it, I can't get to hear that.
Yeah.
And it just reminded me of someone else saying they had something about a clot and they was
Yeah.
driving down here, so.
Yeah,
There's an ad out there saying that.
yeah, but does that mean every woman who's on the pill has to go to their GP so they can?
It's
Yeah,
funny, if someone
no.
came in, I don't know, John, if you'd agree, and said, I want a thrombosis screen because I'm on the pill, we would just say, if you don't have a family history,
Yeah,
we wouldn't be doing bloods on you looking for that, yeah,
No,
so.
I know, but that's,
yeah.
I must listen out for that again. Susan,
And
when I
do
let
you know what, there'll be some drug or something, that'll
There'll
be
be a-
sponsored by somebody that.
Yeah. Now, obviously, some drugs are pro-thrombotic so that they can cut, and the pill would be one of those. So again, it's about prescribing the pill, knowing all your risk factors, any history of previous clots, being overweight, being inactive. So yeah, it's not something we can ignore, but I don't think we need to screen every young person in the country who's on the pill.
Yeah, yeah, I agree. Okay, another one there is, my brother and sister recently were diagnosed with a heart condition, but they were heavy smokers and overweight, which I have never been. Should I be screened?
So depends what the heart condition was. Again, was it the plumbing, the pumping, or the electrics, you know? So what heart condition it was. I think, yes, that's brilliant. You're not smoking and you're not overweight. That's fantastic. But genetics does play a key role, and heart disease is a genetic thing. So it depends what age you are, whoever's asking that question. But really, it's about looking at your own overall level of risk. And there are different risk scores we can use. One of them is the Q risk, and it'll plot your risk of having a heart attack within 10 years. So it's hard to say whether you need to get checked out, because I think the biggest thing is what we were talking about today. Know what your lipid levels are, know what your blood pressure is for starters, so know your numbers and have all that information first, and then you can decide what your risk is and should you be screened for heart disease. For coronary artery disease would be a CT scan of the heart. In the public system, there's really poor availability for that. So a test isn't really the answer. It's looking at your overall lifestyle and knowing what it is.
If you went into your GP with that question, and you hadn't had your bloods done in 5 or 6 years, they would probably do your bloods so that they could get your lipid profile. And then, as Shirley says, we use a thing called Q risk. It's a really interesting, if you Google it,
You can do it
find
yourself
and
online.
you can do it at home. And
Yeah.
what it does is it puts in a whole load of your own risk factors. So your age, your gender, whether you're on a blood pressure treatment. Be interesting to see if you can even bring it up there. And a whole range of whether you've got a family history, and it's in a first degree relative under 60. So having an 85-year-old, you know, grandparent who had a heart attack isn't really regarded as a high risk. And then you put in your weight, your height, whether you're a smoker, and then your ratio between your good and your bad cholesterol. And then this number pops out, and it'll tell you what your risk is of having an event in the next 10 years. And the most important thing, though, is that you should compare it. At the bottom, it says compared to a healthy person of your age and ethnicity, because everybody has some risk. And the older you are, the higher the risk will be, because something is more likely to happen. But it's worth doing for yourself in the sense that you'll see, well, am I roughly right for my age?
So I had a young woman in my clinic the other day, and I did her Q risk score, and she said she was 8% chance of having a heart attack in 10 years. And you think, well, that's grand. But for somebody of her age with no risk factors, it should have been 4%. So that's fine. So her risk was doubled. So that, it's a good way of looking at that. 8% is fine, but it should be 4%. So if that continues, it keeps doubling and doubling, the risk gets higher. So it's a really useful visual way of understanding, especially in the younger population, because we are seeing I'm seeing a lot of high lipids, obesity, smoking, high blood pressure in the younger cohort. So,
and it's funny when you show someone those, you get this little kind of square of yellow and purple faces, and the purple is the higher risk. And some people look at that and they look at 8% and they go, sure, that's fantastic. That's really low risk. And other people go, oh my God, that's such a high risk. Because we all have a slightly different perception of risk as well, and based on our own experience. So you kind of have to then make a decision about, you know, are you going to go on a statin? Will also depend on how you see this risk and what you want to do. But I'll sometimes as well, particularly for a smoker, you can turn the smoking on and off, and then you can show them, well, if you stop smoking, this is what happens to your risk. It's a really, and they get it's the thing that will bring them closest to their age, their own age risk. It's really powerful. I remember doing it when I had discovered it years ago. I did it with my father, who was in his 70s, and like his 10-year risk of an event was something like 30%. And actually that was probably quite good at, you know, at mid-70s or whatever he was. And, you know, so you can just kind of do it and see where you sit in terms of your own health. It's a really interesting thing. See if there. Oh, a link.
Yeah, we can't get it up here. It's just called the Q risk 3. Just Google Q risk 3.
Yeah, and you'll find it.
Yeah, you need to know your blood pressure and you need to know what your cholesterol is. So you need to have the information. Yeah, but it includes having inflammatory disease like rheumatoid arthritis and a few extra things like that. So it's very specific. It's good. It's good.
Yeah. Right. Okay. Listen, if we have.
That's it.
Oh, there's one more. Sorry. Is great gum health good? Oh, this would be, you'll be all over this. Good dental health. Is that important for your heart health?
Well, I would, yes. I mean, Ireland, we're not known. My son went to America recently. He says, it's great, now I'll go over here and get all my crowns and caps and everything done on the teeth. And our dental health is not great in this country. But for me, it's really about the risk of infection. So if you've got poor dental health and your gums are inflamed, infection can get in there and that can travel down to the heart. Might not necessarily cause a heart attack, but it can cause inflammation of the heart, which is not a good thing to have. So yeah, good dental health, I'm sure. Is there anything else?
Yeah, no, that's what I would think as well. It's to do more with your valves of your heart. If you have any valve problems, like you'd actually be advised, if you're going to the dentist, to take an antibiotic to cover dental procedures. She's been really, I presume, so sorry, I don't know if it's a girl or a boy, but she's been excellent. Okay. All right, listen, thank you. I suppose we'll finish up now and have a cup of tea and say thank you so much to Shirley. That was really just brilliant, and for handling all the questions.
Good audience.